Revital Vision is a clinically proven, non-invasive, perceptual learning vision training program. It facilitates neural connections through computer-based visual training using Gabor patches. Clinical study patients improved by 2 lines of visual acuity and a 100% increase in contrast sensitivity.
Revital Vision's online training program provides an effective alternative for improving vision and overall well-being.
Ernest lived with a lazy eye for years, adapting until his good eye began to fail, prompting him to seek help for his lifelong condition.
Well, I couldn't drive. I couldn't read with this eye. I was told that it can't do anything from being 9 years old. But now, they can do something. I know they can do something. It's proved it.
The improvements to Ernest and his lazy eye haven't come through invasive surgery, but through Revital Vision's home-based vision training app, which is personalized for each patient. The app is clinically proven to improve vision across a variety of conditions, including keratoconus, nystagmus, retinal disease, and to improve the quality of vision after cataract and laser refractive surgery.
We use brain science and algorithms to improve vision. What our software does, it stimulates the visual cortex in a very unique manner. The eye is only a window, so if we can manipulate or improve the processing capability of the brain, we can improve vision.
Interestingly, when we started looking at it, the 3 groups were people with eye problems such as lazy eyes, nystagmus, inherited eye diseases, people with low vision, that we were trying to get the best out of it. We've shown good development there. They try Revital Vision and notice they're getting better vision. But I think most of us have heard the adage that we only use a tiny percentage of our brain's capability. And this is a scientifically proven way to upskill the neurons in the brain that see to make them see better.
We have patients who are in their teens and we have patients who are in their 70s who are able to use the technology quite easily in their home environment, and that has enabled something that's actually quite a complex technology to become very relatable and accessible for an application like this with huge benefit. Every patient that I've been involved with on the path with Revital Vision has noticed subjective as well as objective improvement in their vision.
More than 10,000 patients have completed the program, resulting in brighter, crisper, sharper vision.
Okay, very good morning, good afternoon, good evening, and good night to some of the viewers of this webinar number 7, and the season is number 6. So I would like to extend a warm welcome. I am Ramesh Kekunaya. I'm tuning in from India at this point of time. And we are back with the Saturday webinars. And WSPOS is very, very pleased to present this webinar number 7. And this is a special one because it's a independent medical education. This time is sponsored by Binox and Revital Vision. Today we have Dr. Rich Hurtle. All of you know how famous Dr. Hurtle is. He has contributed very, very significantly to pediatric ophthalmology and strabismus, specifically in the field of nystagmus. And he is also an executive bureau member of WSPOS. I would like to extend a warm welcome. Over to you, Rich.
Thanks, Ramesh. It's a pleasure again to be part of the webinar series sponsored by the multiple sponsors you see listed on slides here. And I'm really privileged to be able to share this webinar with a series of international participants. And I'd like to introduce them. Dr. Carla Saavedra from hopefully I can say this correctly, Villarreal Children's Hospital and Visual Center in Cochabamba, Bolivia. Dr. Dongshang Yang he's the Director of Visual Rehabilitation Institute at IR Children's Hospital in China. Dr. Matteo Baldi, he's at the Eye Service Department of Neuroscience, Rehabilitation, Ophthalmology, Genetics, and Maternal Sciences at the University of Genoa in Italy, and Dr. Sampadra Kulkarni from LV Prasad in Hyderabad, India, and Dr. Vivek Warkad, who's the consultant and the head of pediatric ophthalmology and strabismus, as well as neuro-ophthalmology at the Child Sight Institute at Bhubaneswar, India. Thank you, and we look forward to a wonderful seminar this morning.
Thank you so much, Rich. I just have some announcements to make before we start. The first one is, if you have any questions, type your questions or even the comments on the YouTube channel where you have logged in. We will try to answer them immediately if possible during the webinar live, or if not possible, we will get back to you. You can send those email to admin@wspos.org. And also, if you want a participation certificate of this webinar and also attendance certificate, you can email admin@wspos.org. Without much delay, I would like to straight away get into this independent medical education webinar. The title is Science of Amblyogenesis. This is a topic which is very, very important. Whoever is taking care of children, irrespective of any specialty you are, and also adults with amblyopia, because more and more newer treatments are coming. So we would like to start this webinar with the talk by Dr. Matthew. Over to you, Matthew. You could start on your topic. The topic for today is molecular etiology and genetics of amblyopia. Over to you, Matthew.
Good afternoon, everyone. So I'll share the presentation. Okay. So, can you hear me?
Yes, go ahead, Matthew.
Fantastic. So, the molecular mechanisms of amblyopia are grounded in a simple truth. Neurobiological differences, even within the same species, arise from a combination of environmental and genetic influences. In the visual system, early wiring is driven by intrinsic cellular programs, but then activity-dependent refinement takes over. According to Hebbian theory, as illustrated here, inputs from, for example, the left eye that effectively activate postsynaptic neurons are strengthened. Meanwhile, inputs from the right eye, if poorly correlated, became weakened. This principle is vividly observed in amblyopia, where synaptic strength differs microscopically between the dominant and non-dominant eye. Experiments by Frankel and Baer in the mouse visual cortex reveal a two-phase process following monocular deprivation. First, there is a rapid awakening of the deprived eye's cortical responses, then a strengthening of the non-deprived eye's inputs. This dynamic shift underscores the flexibility, but of course also the vulnerability of the developing visual system. So, what cellular mechanisms drive this process? They are known as long-term depression and long-term potentiation. And the key question is this: is synaptic depression in the deprived eye due to mere inactivity, or is it caused by inappropriate activity that fails to align with cortical patterns? The answer, supported by strong evidence, is the latter. And of course, this form of long-term depression, LTD, is homosynaptic, meaning it is triggered by the very same synapses' own misaligned activity and not by influence from surrounding synapses. During the critical period, sensory deprivation triggers long-term depression-like mechanisms seen, for example, in hippocampal models, and MDA receptor activation, AMPA receptor dephosphorylation, and eventually AMPA removal. The result, a weakened synaptic response in the pathway from the deprived eye, contributing directly to amblyogenisis. Zooming in further, we can say that synaptic depression is mediated by AMPA receptor internalization driven by weak NMDA receptor activation. This triggers, of course, intracellular calcium influx, which activates phosphatases that dephosphorylate AMPA receptors, leading to their removal. The outcome is a decrease in synaptic transmission and cortical responsiveness to the deprived eye. In contrast, for the non-deprived eye, long-term potentiation mechanisms prevail. So we can observe, for example, AMPA receptor insertion, increased dendritic spine motility, and, of course, enhanced synaptic strength. These changes are not just electrical, they are also biochemical. For example, in the mouse visual cortex, even brief deprivation triggers rapid dendritic spine remodeling, and this is mediated by proteolytic cascades. This starts with the TPA that activates plasmin, and of course, before plasmin, plasminogen, which breaks down components of the extracellular matrix. And this process reshapes synaptic connections in response to altered visual input. Both TPA and matrix metalloproteinases play critical roles in remodeling dendritic spines, not only during development, but also in pathological plasticity, like exactly in amblyopia. And these enzymes are part of the biochemical machinery that reshapes synapses based on experience. Turning to genetics, so the second part of my presentation, while amblyopia's risk factors like strabismus, of course, and also refractive errors are heritable, not everyone with those traits develops the condition. This suggests, of course, a sort of genetic predisposition that modulates susceptibility. Identifying genetic biomarkers may lead to earlier diagnosis, more targeted screening, and of course, individualized treatments. Recent discoveries indicate that amblyopia may stem not only from abnormal visual experience, as we all well know, but also from neurodevelopmental vulnerabilities. And this might explain individual variability in treatment response and opens the door to personalized therapeutic strategies. Genome-wide studies have identified more than 15 genes associated with amblyopia. Interestingly, many are not directly involved in ocular development, but rather in neurodevelopment. For example, PCDH-A4 and also CACNB2 contribute to synaptic signaling and circuit formation. Other genes, like, for example, DCP1B or ZNF831, regulate transcription, RNA modification, and, of course, protein degradation. These are all processes essential to neural functioning, suggesting that amblyopia has a central, of course, and not just a peripheral origin. Genome-wide studies have identified almost 15 genes, but pathway analysis reveals two major networks in amblyogenisis and in the genetic too that correlated. The first involves amyloid precursor protein and calcium signaling that is essential to synaptic plasticity, and the second one of these two pathway of these two major networks is the network that centers on PTEN, that is a tumor suppressor gene, and also on different pathway transmit signals which regulate translation and also neural development. And these genes regulates, for example, brain size, influence also retinal gate junctions, and also they are all crucial for visual processing. Together, all these findings reflect a growing understanding of amblyopia as a condition that is shaped not only by visual input, but also by intrinsic neural and genetic architecture. And this integrated view holds the promise for new diagnostics, personalized treatments, and also, of course, a deeper appreciation of the brain plastic potential from a physiological, but also from a pathophysiological point of view. Quoting the famous Alfons von Graefe that you can see here, he said that amblyopia is the condition in which the observer sees nothing and the patient very little. We might say that although much remains unclear in the complex world of amblyopia, research is allowing us to see it with ever greater clarity. And thank you for your attention. And also, it's a great honor to be here. Thank you.
Thank you, Matteo. You could probably stop sharing the screen. That was excellent. That was tremendous. I think it's very difficult to try and summarize such a deep in 8 minutes, but there are a couple of things I think what maybe as a group we could discuss, and we could begin with this. One is that using what we know about molecular biology in terms of intervening either as a preventative measure or as a treatment measure. So for instance, if we know that there's an embryogenic situation in the pre-chiasmal visual system, strabismus or retinal disease or deprivation or anisometropia, is there a way you think we can inhibit the irreversible changes in the visual cortex by using what we know of what you've found out or with the molecular biology? Are there a particular group of molecules or methods that we could halt this degenerative process, such as long-term depression, or accentuate long-term depression? I think that would be fascinating. The second thing to discuss is, would the same thing be true for understanding genetic treatment? Could there be a way to intervene genetically so that the neural pathways would be resistant to the pre-chiasmal condition that causes amblyopia?
Yes, it's a very it's a very big discussion, the one that we can start from what you have said and from my presentation. So what we have to understand is that amblyopia is characterized by a lack of visual development in one eye due to abnormal visual experiences during critical periods of development. And molecular biology can help in a sort of way elucidate the mechanisms of neuroplasticity in the visual cortex, providing insights into how we can enhance and restore this visual function. From a pharmacological point of view, we can identify theoretically specific molecular pathways that are involved in visual processing and neural development, and this can bring us to develop pharmacological agents that, for example, promote recovery of visual function by enhancing neurotransmitter activity or modulating signaling pathways in the brain, because, as I explained, long-term depression and potentiation are the basilar molecular mechanisms and that's why amblyogenesis happens from a cellular point of view. And I think that it's very interesting also to understand that from a neurodevelopment insight, we can investigate the molecular basis of this process and also the disorders that co-occur with amblyopia, so that happens together with amblyopia. And so we can also have an approach that is comprehensive of the treatment, not just of amblyopia per se, but also of the condition that can lead to this one. Of course, very important could be also the rehabilitation techniques that can be better studied and better explained, also from a genetical point of view, knowing better what happens before amblyopia happens.
There's some questions from the audience, and I was thinking of this too. Do you know of any abnormalities that occur, either acquired or congenital, primarily of the brain, that behave like amblyopia, so that actually the amblyopia was not initiated by the prechiasmal system, but that the exact clinical conditions, the same types of clinical situations, are the result of either an acquired or a developmental disorder of the visual cortex or lateral geniculate?
Well, so in general, of course, we have visual cortex abnormalities that we know that that happens primarily in the primary visual cortex, and so we have, of course, a reduced activation and also an altered connectivity in individuals with amblyopia. And so this, of course, affects how visual information is processed and integrated, not only from a physiological point of view, but also from, for example, a psychological point of view. Then we know that there is also, of course, a reduced neuroplasticity, and some authors suggest that there could be also an alteration in the interhemispheric communication. So there is usually a difference in the communication between the two hemispheres of the brain, and this could be in part, but not only explained by the amblyogenesis process, but also from alterations or disorders of development that could be independent from amblyopia. And in general, amblyopia can be associated also with deficits in visual perception, attention, and of course also in spatial connection that could be very important also from a semiological point of view. And these aspects, of course, can be linked to underlying brain abnormalities. But of course, a lot of neurodevelopmental disorders are characterized by, for example, strabismus or refractive errors that are both causes of amblyopia in different ways.
Many decades ago, I think Van Noorden showed in animals, and then Dr. Jampolsky kind of wrote about this. You can increase the length of the critical period, especially in deprivation amblyopia, if you prevent both eyes from being in early development. And what's your understanding of how the brain works in that situation, whether there is potential for treatment, or in how would that look?
I just want to interrupt here. Probably we will stop this discussion right now. We will have to move on. I would ask Vivek to share his presentation, and we will come back to this discussion. As Vivek is opening his presentation, people are joining us from all parts of the world. We have people from China, we have people from India, we have many delegates from USA, we have from Greece, Indonesia, we have Oman, Argentina, Bolivia, Serbia, and Brazil, and Italy, and Spain, and so on and so forth. So Vivek, over to you. We will have your talk, and probably we'll continue the discussion later. Vivek is going to talk about lateral geniculate nucleus and the visual cortex. Over to you, Vivek.
Yeah, can you hear me, Dr. Ramesha?
Yes, go ahead, please. Thank you.
Yeah, so very good evening to everyone. So I am going to talk today about, the lateral geniculate nucleus and, the visual cortex in the context of neuronal basis of amblyopia. I do not have any financial disclosure. So if you look at, today we are learning an entity called as, the amblyopia, which has a prevalence varying from, 0.6 to 4.7% in different part of the globe. And today I'll take you through what is the pathophysiology of amblyopia, understanding the plasticity or, the critical period of visual system, and also to learn what changes in the lateral geniculate nucleus and visual cortex that happens in patients with amblyopia, and also the structural and functional assessment of the lateral geniculate nucleus and visual cortex using the functional MRI. So as we all understand that the amblyopia is caused by the abnormal retinal inputs during the childhood, and the underlying neural deficits are primarily found in the central nervous system. So if you go by a very simplistic way of explaining the mechanism, if you would have the abnormal binocular interaction that leads to the competition between the two eyes due to the conflicting images, that leads to the binocular connection underdeveloped. However, the retinocortical connections are usually normal. And the second mechanism is when there is a form vision deprivation, like in patients with the congenital ptosis, or for that matter the congenital cataract, then there is a lack of stimulation of fovea. So this leads to both the retinocortical connection as well as the binocular connections get underdeveloped. So this is a simplistic way of explaining how does these two stimuli they get differentiated in terms of the different causes of amblyopia, like strabismus, anisometropic amblyopia, or visual deprivation amblyopia. So let's understand, what is the plasticity or a critical period of the visual system. So basically, this refers to a fine tuning of, the neuronal connections along the visual pathway. So if you can appreciate here how the lateral geniculate body that undergoes, the changes, like at 8 weeks of, the life, it appears, and then the connections start developing with the retinal ganglion cell by 10 weeks, and the connections with the visual cortex by 26 week. So basically this fine tuning continues few years after birth. And then the most two things that are important or necessary are, number one, the foveal stimulation, and there has to have the normal binocular interactions. So what are the few facts that we all should know about the critical period? There is nothing like a critical period. It's a big, long, the ongoing process. If both eyes functions equally, then the number of cortical cells connected with each eye, they are equal. And usually they account for almost 10% of the cells that are connected uniocularly, and about 80% are binocularly. So the maturation of the visual system is completed by the inhibitory GABAgenic interneurons. They are sitting in the layer 2 and 3 in the V1 cortex. And the inhibition of these interneurons is probably thought to be to prolong the plasticity. So this is what, on a similar context, Dr. Baldi was alluding in his talk that, AMPA endocytosis or a MMP9 hyperactivity, if we can inhibit, these GABAgenic or, the inhibitory signals, probably we have the opportunity to delay the plasticity and then get, the other sort of intervention to prevent the amblyopia. So if you look at the history, most of what we know about the impact of amblyopia on CNS is based on the animal models and the postmortem histopathology analysis by creating artificially induced strabismus, anisometropia, and unilateral lead sutures. So if you see the Hubel and Wiesel, they won the Nobel Prize in Physiology for describing the extent of damage to the ocular dominance column in kittens by sufficient visual deprivation using the critical period. So as we understand the critical period, at the same time, we need to see what these animal experiment they have taught us, that this leads to the shrinkage of ocular dominance column of the deprived eye and swelling of the favored eye. A similar changes were found in the lamina of lateral geniculate nucleus. So very recently, if you see in 1980s, Dr. von Nuden and group, they have worked on or got an opportunity to look for, the postmortem human brain histopathology in anisometropic amblyopes, where they have first time showed that the human amblyopia is accompanied by a structural changes in the afferent visual pathway, very much similar to those observed in the animal models. And this also helped to validate that the macaco monkey models for the further study to clarify the basic mechanisms of amblyopia, which Dr. von Nuden and group, they have worked on the animal models as well. So what he found that there is a decrease of cell size in a parvocellular layers which are innervated by the amblyopic eye. A very similar opportunity to test in a patients with the strabismic amblyopia on a human brain biopsy. He found that the cell area size in layer 2, 3, 5 of the left eye from the amblyogenic eye were significantly smaller, almost 25%, than the respective layers from the normal eye. So let's move on to, what is the recent neuroimaging research, that is looking for the impact of amblyopia on CNS. Let's understand how the microstructure and functional integrity of the CNS that gets altered by the amblyopia. So if you see the paper by Dr. N.P. Miller, he has very nicely described, how the lateral geniculate nuclei, gray matter volume, and also the primary visual cortex and even the extrastriate cortex get altered due to the amblyopia. So in his study, he have used the MRI methods to understand the functional integrity by looking at the functional MRI, where the blood oxygen level dependent, that's the bold signals, they have been used, the neural activity to estimate the metabolic demand. Contrary, the structural integrity was checked by the diffusion MRI and voxel-based morphometry. So basically, the diffusion MRI helps to identify the white matter pathway by diffusion of the water molecules, and VBM helps to assess the local gray and white matter volume. So if you see in his paper, he has looked starting from retina nerve to the primary visual cortex. So very categorically, the reduced bold activation was noted in lateral geniculate body, primary visual cortex, and to some extent in the extratriate areas. So you can appreciate in this slide, there was a reduced bold response, decreased gray matter volume in the LGN of amblyopic patients. However, the precise characterization of these functional deficits as they relate to the amblyopia subset is currently lacking, and probably that's the important avenue for the future studies. A very much similar changes were noted in primary visual cortex in terms of weaker V1 connectivity, indicating that there is a disruption of the cortico-subcortical transmissions, reduced gray matter volume in V1, and also the reduced bold activation in V1. So with this, I just want to end up with this last slide. What about the adult amblyopia? What happens to the LGB and V1 in adult amblyopia? So this is a very interesting study by Wen and Wen group from China. They have looked at the 3T and 7 Tesla bold FM MRI, where they have found that in fact they have challenged the traditional view of pure cortical origin of the amblyopia. Rather, they ended up with showing, there is a selective P layer deficit of the geniculostriate and the corticotectal pathway, representing that amblyopic deficit could be in the form of visual acuity, oculomotor control, and also the attention. They have also noted that there is a reduced response found in the superficial layers of superior colliculus. So I think it's not just a cortical, but it's a subcortical, including the superior colliculus could be also one of the area of interest. So with this, I want to conclude saying that amblyopia involves structural and functional changes in LGB and the primary visual cortex. While the primary clinical criteria focus on two-line difference in BCVA, it is now clear that there are another behavioral deficits like eye movement, attention, color, depth, perception, form, contour, hand-eye coordination, adult amblyopia selectively affects the P-layer pathway in LGB and superior colliculus, highlighting the subcortical involvement to look into the future. And I think the functional MRI is a better avenue to understand and guide the future therapies targeting the lateral geniculate nucleus and the superior colliculus. So with this, I would like to end my talk, and thank you so much. I'm leaving this slide for the audience to understand, what is the functional classification of visual areas, and, where pathways and what pathways, how that can integrate. And probably we can learn in the next sessions of, the webinar from WSPOS, how it is implicable in terms of, the future therapies that the world is looking for. Thank you very much.
Thank you, Vivek. That was excellent. I really appreciate it. I think we're running a little behind, so I just would like you to touch on one thing for a minute or two before we move on to the next talk. And maybe if this is a continuation of the previous talk. Are there ways of understanding if there's pre-programmed development of the visual cortex genetically, and are diseases like cortical visual impairment, is the vision loss associated with CVI similar, or how is it different than amblyopia? If you could kind of touch on those, we can discuss it a little more at length later. But just what are your initial thoughts on that?
Yeah, I think, in terms of the, apart from the visual loss alone, if you look at the patients with CVI, whichever the area that has been damaged, because of the cortical spasticity, we tend to give them a therapy where the surrounding area takes over the function of, the area which is damaged. So I think, yes, definitely there is a difference. Apart from the vision, there are other cognitive functions that gets affected in patients with CVI if you look at the patients with amblyopia. Because as of now, as per our understanding, amblyopia is a cortical disease. Apart from that, the extrastriate areas, or if you go a little bit down, like subcortical areas, if you see the involvement of those areas, then you will find, apart from just a vernier acuity, there is a involvement of, the form, color vision, motion perception, hand-eye coordination. So amblyopic patient would present with those ones. However, there are a lot of studies, ongoing studies, which are going on, where they are looking at how the patients with adult amblyopia, they do have the other cognitive functional abnormalities.
Thank you.
Okay, let's talk. We learned two aspects, that is the structural and the genetic aspect. Let's go into the next talk. This will be the problem right now is myopia. So she would like to give an overview of myopia progression and amblyopia. Over to you, Sampada. As she's sharing the slides, I think many people from around the world are joining us.
Am I audible?
Italy? Yes, go ahead.
Yes.
Okay. Hello all, I'm Dr. Sampada Kulkarni, working as a pediatric ophthalmologist in LV Prasad Eye Institute. It's an absolute pleasure to be a part of this esteemed webinar today. At the outset, I would really like to thank organizers of this international forum, especially Dr. Ramesh Kekunia, who has invited for me to talk here. It's an honor to contribute at this global exchange of knowledge and idea, and truly appreciate for the opportunity. So without delaying, I don't have any financial disclosures. We'll start with
just one thing. Can you share the slide view?
Oh, sure. Is it okay?
No, wait.
Okay, just give me a second. Just a second. You can see. Okay, so we'll start with the story of a 12-year girl who presented to us 5 years before. She was a case of unilateral myopia or anisometropic myopia with visual acuity of 20/30. She was using Myatro at night time in the right eye from past 2 years, and she was continuously following up, as you can see in this, till 2025. So her current prescription, which we gave in the last visit, which was recently, was minus 13.5 diopters in the right eye and minus 1.25 in the left eye. Why am I stating that? Though she was maintaining outdoor activities, she was using Myatro, using contact lenses also regularly, we have seen that there is a trend in axial length increase in both right and the left eye. Why are we discussing this? Because we are trying to link amblyopia and myopia. Now we know that both myopia and amblyopia are major concerns for us. Though historically it was considered to be separate, now there is a growing evidence that there is an overlap. And we are running through this talk to understand their relationship and management. As we all know, myopia is an increasing trend globally and expected to affect 50% by 2050. We have also known that younger the onset, faster is the progression, higher is the risk of complications. Environmental and genetic contributors are also one of the risk factors for myopia changes. What happens in amblyopia? We have seen that there is a blunted accommodative response. Are my slides visible?
Yes.
Yes.
Okay. Yes.
They're fine.
Yeah. So there is a blunted accommodative response, that is accommodative lag in amblyopic eye, and that ranges from 0.75 to 1.5 diopters in amblyopic eye compared to 0.25 in normal individuals. Why do we want to know that? Because there is a reduced accommodative facility. There is a slower recovery time when there is a switch of focus between distance and near as well as while reading. There is a greater variability and microfluctuations which will happen exceeding those of the fellow eye. When the patient or the child is doing binocularly, the sound eye drives the focus and the amblyopic eye actually under accommodates almost by 15 to 40%. Why it happens? Because there is a cortical suppression, there is a decreased feedback because of the blur detectors in V1 and V2. That causes weak accommodative drive. Now there is an impaired contrast sensitivity, as we all know, in amblyopia, which will blur the signals and arrives late, lowering the gain for the near response loop. As there is a decreased extraretinal match between the accommodation as well as the contrast and near response loop, there is always a breakdown of the near triage linkage. This causes delayed motor execution and decreased latency of saccades in amblyopic eye compared to the normal eye. So now once we understand that these are all things happening in a patients with anisometropic amblyopia as well as form deprivation amblyopia, let us understand what happens at the retinal levels in these patients. We know that there is an amblyopia which causes chronic blur. From the human studies to understand myopia, from animal models also, we have seen that there is a decreased dopamine. Now everybody knows that dopamine is an anti-myopiagenic factor. Decreased dopamine increases retinoic acid, and because of that, it stimulates the elongation of the eyeball, especially in cases of anisometropia. We also know that amblyopic patients have a contrast sensitivity which is low because of the reduced LNM cones, which actually mimics a dim light situation in amblyopic eye, which is one more clue towards myopiagenic clue. These all changes make us understand that if there is anisometropic amblyopia, there may be a myopic shift in the patients when there is amblyopia. Coming to the choroid and sclera, as everybody has now understood that myopia actually causes choroid and scleral remodeling, what happens in patients with amblyopia? As there is a blur, we also know that with the OCT studies, there is a rapid choroidal thinning in patients where there is a high myopia. When there is amblyopia and myopia, there is a scleral remodeling with upregulation of MMP2 and TIMP1 in the sclera, which actually causes increase in the length of the eyeball. Now that both these factors of blur and increased length of the eyeball share a downstream pathway for association between myopia and amblyopia. What happens at the cortical level? As we know that suppression reduces accommodative feedback. Now there is a reduced accommodation causing the lag. When there is a lag, there is a hyperopic retinal defocus during the near work. We all know that myopia progression can happen if there is a peripheral retinal defocus which is hyperopic. Now, these signals will actually cause or may be causative for sustained myopic drift. What is the intersection point? Now that we are understanding that there could be some relation between anisometropic myopia and amblyopia, we know that there is a significant risk of amblyopia when there is a difference between two eyes of 1.5 diopters. We have understood that there is an under-accommodation in more myopic eyes, and as there is an amblyopia, there is a poor compliance with the spectacles as well as amblyopia treatments. What happens there? There is a blur which increases the demand of accommodation. That will actually try to focus the eye or the image on the retina. As there is an under-accommodation, there is an ocular growth and myopia development. Do we have evidence? There are multiple studies done from 2020 onwards which are trying to study the association between myopia and amblyopia. Like a PEDIC group who stated that younger the age, higher is the baseline myopia, more is the risk of amblyopia, and faster is the progression in both myopia and amblyopia. Study done by Roberts et al. From the PEDIC group actually studied about the amblyopic eyes and the accommodative changes which are happening in them. And they have concluded that in amblyopic eye, there is a persistent accommodative lag. And for that, we need to actually do a NOT retinoscopy to understand is there any change between the two eyes. Tur et al. Actually studied about anti-accommodation, which is linked to the poorer outcome in patients with amblyopia. Now, are we heading towards genetics? Yes. There are few studies like Dr. Bali also quoted about myopia, amblyopia having a genetic association. Both myopia and amblyopia also share an overlap with PAX6 GD2 locus on chromosome 15. It actually states that the SNPs and GIC2 plays a role in retinal patterning as well as WNT signaling at the level of retinal progenitors, which could be susceptible for the anisometropic cases, could be overlap even genetically between myopia and amblyopia. Do we have environmental amplifiers? Yes. Now we understand that the amblyopic patients have a hypoaccommodation and causes retinal blur. The more the accommodative lag and higher is the near work, there is a hyperopic defocus causing myopic shift. The children who have amblyopia actually avoid sports. Along with that, reduce exposure to the ampliflux lux less than 15,000, which actually causes lowers dopamine, and can cause increased myopia in these patients. Are there any treatment interaction? Yes. There are studies which are done cross-sectional as well as prospective to understand that what happens with the patching in the patched eye. We have seen that there is a transient jump of minus 0.25 in the patients, but on prolonged prospective studies, there is no axial length jump in the patients with patching. We all know that 1% atropine has been used and tried for amblyopia treatment. And there are studies quoting that there is a rebound myopia in the sound eye, necessitating the help for monitoring the axial length and repeated refractions over the follow-up in these patients. There have been also studies done to understand is there any low-dose atropine interaction between myopia and amblyopia, and the study stated that low-dose atropine is safe in amblyopia therapy as well as myopia progression reduced by 45 to 60%. So what are you concluding here? Accommodation deficits in amblyopia are actually driven mainly by the cortical suppression. We expect larger and more variable accommodation lag, especially in anisometropic cases. What do? We try to measure monocular as well as binocular lag at baseline. Especially with the help of dynamic retinoscopy or NOT retinoscopy, to understand the objective accommodation. Once we know that there is an accommodation difference between, we can tailor the near vision support if there is a hypoaccommodation, especially in amblyopia patients, by giving near ads or encouraging them with a contrast-rich material. Also, rather than waiting for patching, we can actually incorporate binocular training to normalize the accommodative loop in patients with anisometropic amblyopias and myopias. So what is the take-home message? After giving this talk, we have understood that amblyopia can cause automatic acceleration in myopia. Accommodation deficit could be a bridging gap between myopia and amblyopia. Anisometropic blur could be a key driver for myopia progression. And in such a situation, though they are separate, but we need to do treatment and management simultaneously. How do we do that? We should always have an early integrated and tailored intervention for this visual success by monitoring axial length in anisometropic amblyopes Adding myopia control modalities if there is a fast growth, encourage more than 2 hours of day outdoor activity. Along with that, check for monocular as well as binocular accommodation with the help of not retinoscopy. I would like to thank for this wonderful opportunity to share my knowledge. I would be happy to take questions. Thank you.
Thank you, Sampada. That was unbelievable. We have a few minutes for some questions, and I think that what I think is important is that the mechanism for amblyopia or amblyogenisis in the myope, whether it's a low, medium, or high myope, is mixed, isn't it? It's not just the differences in the image quality, but image size. And also you suggest that the efferent system may have a role in causing either one of the mechanisms, either an anisometropia mechanism or a blur mechanism, a deprivation mechanism, because of the accommodation system involved in this. What's your sense of how, if we improve the image quality in the myopic eye, in the more myopic eye, would that be in treating the all of the aspects of amblyopia in myopia?
It's a very excellent question, actually. And we always try to reduce the anisoconia by the help of giving contact lenses. So it is always good measure to start with the therapy where we reduce the size of the images or the difference between the images, especially in cases where there is extreme high myopia and we know that there is anisoconia. So it does affect that if the images are not equally formed, there are also and cortical suppression if the images are not of good quality. So that does make a difference if we try to start the therapy with contact lenses as soon as possible to reduce the image size.
And what about treating the efferent system? Have you found or heard of actually some forms of orthoptic vision therapy for the accommodative leg and the accommodative deficiencies improving the amblyopia consequences? So
Yeah.
can treating the motor system make the sensory system better?
Yeah, actually, there are studies done by PEDIC group about the accommodation and what they have come across, or there are other studies done also by not retinoscopy, and they have come across that the children who have less visual attention when they are doing amblyopia therapy or they are not keen, you should actually go back and check for the accommodation lag. And once you give them a near ad when they are doing activity, there is an improved response and adherence to the amblyopia therapy as well. So that's a very good point. We should look into day-to-day clinic that if there is a non-compliance or poor adherence with the therapy, then we should actually look for the mechanisms which are both motor and sensory at the same time. And also, if at all you're seeing that there is a accommodation lag and which we are not able to overcome, it's good option to switch directly over the binocular therapies rather than continuing with the traditional patching therapy.
Mm-hmm. That's very good. Thank you.
I just had one question and just a comment. Do you think this myopic, basically the anisomyopia, amblyopia, do you think they are different breeds compared to a normal amblyopia? Or do you see a common factor in a myopia? Or because the progression of this can happen in the anisometropic eye as well as in the normal eye. So if there are differences, do you think it's only accommodation or anything else? I just wanted to ask that.
So whatever literature or in the clinic experience which we have, it's not always one factor which is associated, and we cannot generalize based on one theory because there are multiple theories. One is that there is an accommodation lag. Along with that, there are other theories like environmental factors also do play a role when we are talking about myopia and amblyopia. So I would say that not one factor, but we should consider all the factors, not just accommodation, but at the same time, is there any genetic association? Along with that, amplify the environmental risk factors, all these things. Along with that, if we can get OCT done for these patients, all might help to give the better outcome for the patients rather than one therapy to be followed. So it should be individualized rather than generalized for each patient.
Thank you. Thank you, Sampada. I think we need to move on. As a summary, I think myopia and amblyopia, there are some similarities. And when you all take care of this myopia progression, which is a very hot topic at this point of time, we need to consider and customize the treatment. Probably, I don't know how many of us check real orthoptic assessment in terms of accommodative lag, accommodation, and all the other behaviors. Probably it's time to think about it as a very different, aspect. And also, in terms of assessing the amblyopia per se, I think we have to think beyond eye, beyond accommodation, and of course, the brain is the main culprit here. With that, I think we will go to the next very relevant topic. Dr. Carla Saavedra, she is from Bolivia, and she is going to talk about clinical relevance in the amblyopia classification. Over to you, Carla.
Okay. I'm going to share my. Okay. You hear me?
Yes, very good, Carl.
Go ahead,
Okay.
go ahead, go ahead.
Thank you. Hello, everyone. Thank you for being today with you. It's a very honor. We are exploring the clinical relevance of amblyopia classification, and while that may sound like a very structured or academic topic, it has huge day-to-day implications for how we diagnose, treat, and support children with amblyopia around the world. Well, see how amblyopia actually is defined. Amblyopia, often called lazy eye, it's a condition that arises during a critical development period of vision, usually before the age of 5. It's caused by abnormal visual stimulation or sometimes a lack of stimulation during this sensitive time when the visual system is still maturing, up to 2 years of age. It affects approximately 2 to 7% of school-age children, and most common form we see is refractive amblyopia. Why is classification important? Because a precise classification allows us to make accurate diagnosis, set realistic expectations for prognosis, and choose the most effective treatment. It also helps standardize studies and public health strategies globally. Okay. Traditionally, we classify amblyopia based on its etiology. We have strabismic amblyopia, where the eyes are misaligned, refractive amblyopia, including anisometropic or isometropic types, and deprivation amblyopia due to the things like cataracts or ptosis. But more recently, we've also started looking at severity-based classification, mild, moderate, or severe, based on visual acuity levels. This is extremely useful in determining treatment intensity and expected outcomes. Another relevant factor is the age of onset and duration. Since amblyopia develops during a period of neuroplasticity, earlier onset and longer duration is usually predict worse outcomes. Classifications helps us to choose the right treatment, patching, atropine, optical correction. It is more or less effective depending on the type and severity of amblyopia. It also helps us predict outcomes. For example, children with moderate amblyopia usually respond very well to part-time patching or weekend atropine, while in severe cases, treatment is more challenging and prolonged. And finally, it helps us identify children at higher risk for poor outcomes, especially when detection is delayed or if they have associated ocular or systemic conditions like strabismus, nystagmus, or prematurity. A clear classification allows us to personalize treatment plans. We can tailor patching duration, choose atropine for better compliance, or which to binocular therapies when needed. Monitoring and follow-up also depend on the classification. A child with mild anisometropic amblyopia might just need glasses and a few checkups, but a child with severe deprivation amblyopia will need intensive therapy and close monitoring to avoid regression or reverse amblyopia. And when patients plateau or struggle with adherence, adjunctive therapies like vision therapy or digital platforms can be introduced to improve outcomes. Standardizing classification. Using a standardized classification systems like one of the from PDIC allows studies from different countries to speak the same language. It improves comparability between studies, supports large-scale meta-analysis, and helps allocate healthcare resources more effectively, especially in underserved populations. It also helps us identify gaps in care. For example, children who from low income or rural communities are often diagnosed later and treated less effectively, which increase the risk of lifelong vision loss. Overlap, challenge and limitations. Overlap between categories in clinical practice. There is a significant overlap between categories in clinical practice. For example, a child may have both strabismus and anisometropia, which complicates classification. We also depend heavily on visual acuity alone, which may not fully capture important factors like contrast sensitivity or stereo vision. There's also variability across clinical and countries in how amblyopia is diagnosed and managed. This makes it harder to compare data or implement universal guidelines. And importantly, classification systems don't yet incorporate promising tools like genetic markers or neuroimaging findings, which could refine our ability to predict outcomes and tailor treatments in the future. The future is exciting. Artificial intelligence and machine learning are helping us screen and diagnose amblyopia earlier and more accurately. Digital therapies, including virtual reality platforms, are often offering new, engaging ways to treat amblyopia, especially for children who struggle with patching. We are also moving toward integrating amblyopia classification into electronic health records, allowing for better data tracking, monitoring, and long-term outcomes. And so we are just at the beginning. Genetic and neurobiological markers may one day help us predict who is at risk and who will respond best to treatment. In summary, amblyopia classification is not just an academic exercise. It has real implications for how we diagnose, treat, and follow our patients. The PDIC framework helps us apply evidence-based, standardized care. It supports individualized therapy and helps us predict visual outcomes. But we'll have work to do. We need to refine our classification tools and embrace technology to keep improving care for amblyopic children around the world. So I encourage with all clinicians, let's integrate classification into our daily practice. Not only will it improve outcomes, it will help build a global foundation for better amblyopia care. Thank you so much for your attention.
Thank you, Carla. That was fantastic. And classification systems and the use of them and the importance of them are really close to some of the work that I've done over the years. And I believe that we can't move forward as a group unless we understand and communicate in the same language and we use the same terms. And I think since the international community is now becoming smaller and more communicative, what would be a mechanism by which we could, as an international community, begin to develop a classification system that encompasses some of the characteristics that were proposed when classification systems were originally developed by Linnaeus, such as things that are live. A live classification system can be modified based on new knowledge and technology and understandings. How can we as an international community begin to develop a classification system of amblyopia that could be used as a foundation for clinical research, interventional trials, and basic research? What would be some ideas that you have so that we as a group could begin to organize ourselves and agree on a classification system for amblyopia?
I think it's important to share our information in a data and speak the same language. I mean, if we use the same amblyopia classification, standardize our notes or knowledge, it will be helpful to take this universal or standardized classification of amblyopia, because as we heard, it's developing with the neurobiological and genetic topics, and we should include in this classification too.
I wonder if any of the other panel members has some thoughts on how we as an international community could begin to do this from a practical standpoint. Would it be doable? Is it something that's conceivable?
I think, Rich, I think it's time to, change the classification, because this is based on the understanding probably many years ago. At that time, there was only one or two options for amblyopia therapy. Now, as we understand more and more about this, especially with the magnetic resonance imaging, probably with the functional variety, we are able to understand many of those. But probably as per the treatment, I think Carl has really put it very nicely with the relevance of what is the etiology. Accordingly, we can put it. And what's the prognosis? Otherwise, every child will be on one basket, and then the child will be getting. As we are getting newer and newer treatment, I think this is important.
So I think that I would want to get your input on this, that an organization like WSPOS could actually collaborate, because we have an international community as members, and begin to come up with a universal classification for amblyopia that can be used as a foundation. So that's kind of what I was getting at. I think that societies like ours that have a large body of international members with a large amount of experience and exposure to the entire population of patients that have amblyopia, including clinicians and researchers, may be in a perfect place to develop or initiate the development of a modern classification system.
Yeah, I think, thank you, Rich. I think we will move on. As others think about a classification, probably, I think people watching around the world, probably they can send us suggestions, and then we must take it forward, something on the classification and also on the understanding part. So I would like to call upon my dear friend, Dr. Dongsheng Yang from China. He's going to speak about amblyopia and the dark exposure. Over to you, Dongsheng.
Hello. Many thanks to Dr. Hurtle and Dr. Kekunaya for your invitation. I'm going to share my screen. Okay, share. And going to play it. Can you see it well?
Good, Dongsheng. Go ahead. Thank you.
Thank you. It's really a great honor to participate in this webinar. So talking about the amblyopia treatment, so we know that it's very difficult to get any improvement for the adult amblyopia. So we know that the animal model that are used in dark exposure that could improve the vision even for adult animal. But there's so far no formal report on the adult amblyopia. So, we have been doing the darkest proposal for 5 years, more than 300 patients got improvement. But it was last year that we got enough adult patient. We reported this on the last year's oval. So I'm going to do the similar report on the adult amblyopia. So the report is based on actually the 57 patient. This is how we do it. There is 3 layers of curtain to build up a dark room. Inside usually there are at least 2 beds and the bathroom. And so our 57 adult patient, which is 109 amblyopia eyes, and so there, more than 80% of patients, they are nystagmus patient. And then some, strabismic, refractive, and formal deprivation, and with nystagmus. That's, our patient. And we test the monocular and the binocular visual acuity, but we report the monocular visual acuity. And the patient with nystagmus strabismus, they participated in this study after surgery. So nystagmus already was reduced with surgical procedure. So if we look at the patient that reached the normal vision, which is this group, you see on the yellow bar, and then also there's a very tiny bar, which means that this visual acuity reached the level of 20/20. If we look at all the data, also a significant improvement. This, on the left side, this is all patient included. Then the right side is the normal vision. They started with the better vision, obviously. So that's in the 65 eyes of the 73 patients that reached the normal level after the dark exposure and the training. Okay. But there are 2 amblyopia eyes had less than 1 line improvement. So those are from the cataract, the patient with cataract and the deprivation amblyopia. But all other subjects had more than 2 lines improvement, and some even more than 5 or 6 logMAR units. That's the patient number. Most patients, that's 29 patients, got 3 logMAR unit improvement. That's this graph indicated. Also, I'm showing you the time course of the vision improvement after for all eyes, for each individuals from day 1, day 2, and day 14. We had patient, trained in 14 days. Okay, so this is for the smaller group that their eye, the visual acuity reached to the normal vision. Okay, if we have the mean of them, show here, then we know the red line is the average time course for the people with, gained the normal vision. Obviously, they started with better vision, usually 20/40, and then they reached 20/20 or better than 20/20. And some people, you may say that a lot of nystagmus patient, 3 to 4 days after surgery, they entered the dark room. This might be the the effect of the surgery, maybe not because the dark room effect. So we have some patient on the 34 eyes of 19 patient who started the dark exposure at least 1 month after surgery. This group patient also get significant improvement as we indicated on the picture. So it's not the effect of the surgery, okay? And also you may ask, is the effect stay long? Now, because the patient is from all over the country, some patient has difficulty to travel, to come back to revisit us. We don't have a lot of patient, come back, but we do have 7 patient, 13 eyes revisit us 3 months later. So their visual acuity, kind of drop back a little bit. But if we do a little more training, their visual acuity will improve again. So it's stay long for most patient. Okay, then we have to also report a patient with deprivation amblyopia failed to obtain the visual improvement. So another point we want to make is the more than 80% of our patients are nystagmus patient. This may not be generalized to other type of the amblyopia. Yeah, long-term result is needed, and good control group will be helpful. So to summarize the results, we would like to say the vision improvement in adult amblyopia indicated that visual plasticity may be activated in the process of the dark exposure, and for the vision improvement in adult. Dark exposure could be an additional approach for vision rehabilitation research in difficulty amblyopia. Thank you. Thank you. Then I can have a question. So I'm going to stop the sharing, and thank you.
Thanks, Dongshine. That was really interesting. I wanted to ask you a couple of things about the methodology.
Mm-hmm.
This isn't just darkroom treatment. You mentioned training. So first,
Yes.
I wonder if you could talk about because maybe it's the training, not the darkroom therapy that does this. And so
Mm-hmm.
I wonder, and could you also describe what darkroom therapy is? Are these patients in the dark completely for how long? So those are, I think, the two things.
Yes, good questions. Yes. So for adult, we know that it's training really, cannot get any large improvement. I think the role of the dark support, actually promote or release the leak in the pathway, and so that allow us to do training and get improvement. So the dark exposure takes 10 days for patient to stay in the dark room continuously for 10 days. So after 10 days, we do like 14 days training. The training is kind of a percept learning kind of thing. We let the patient do some vision task. It's like a game. Let's say to align the some dot, make them leveled. They displayed as some up and some down. Just align them, the visual task. And in some patient, we do binocular training, like major amblyoscope. And for 10 days, every day they do in the morning more than 2 hours, in the afternoon 2 to 3 hours. So that's what we do. And so after 2 weeks, there's some patient actually very interesting. You don't really have time to train them, 2 days or 3 days after the dark exposure, their vision improved dramatically. But some patients, if you don't treat them, the vision is not, see any improvement. The improvement started like, 3 days or 4 days, 5 days training. You start to see the improvement. It's different.
So the other thing is that humans don't tolerate sensory deprivation very well. What are the side effects of spending that much time in the dark? Were there any patients who had any psychological side effects or refused to continue the treatment or left? And what was the data on them? And have you looked at the data from just the dark room only without training?
Yes, that's another good question. So stay in the dark room for that long, it's not that easy. So before we entered that dark room, we started actually with some younger kids. The mothers and the doctors has to educate the kids. We will say this is a very difficult task, but there will be a hope that you got the vision improved. So once the kids understand the situation, we usually put, 2 to 3 kids in one room. The kids in the dark play and see a song, and so there's so many cases. They enjoying the stay. They joking with us. Only 2 days. I want to stay more, and but we do see some patients report say in the very last few days we start to see, when we close the eye, we see some star, in somewhere, and it's, we always, say something like that. But that won't last long. After they come out from a dark room, they start the training. They stop to mention anything. We had any patient, they have any side effect remaining, nobody get the visual acuity lower, if it's not improvement. So, even include some patient with the some degree of retina disorders. It's, there are different groups, but today we only reported the patient with amblyopia, which means no other detectable, disorders. Yeah.
So the audience asked a question again about the darkness. Again, I wanted to ask you, did anybody actually quit the study because of the darkness? And is it total darkness? And if so, the audience, how can the children or adults interact with each other and play with each other in total darkness?
Yes. Yeah, this is a total darkness. And so we had one adult patient quit. And we usually let the patient get into the dark room to stay for a couple of hours, see if they can tolerate it. One of the adult patients, they said, I can't breathe. And 2 hours later, it just came out. And we have another case at a very early stage. And he stayed there for 2 days. And he wants to say, and I miss my grandma. I want to see my grandma. And so it went out. And the daddy came in and said, you have to come back. You have to go back. And the daddy kind of forced the kids going back, and the kids, into the dark room again, stayed there for 12 days and got a very good results. So in these days, we always let the kids and the family and the parents try together, until they feel very confident and they stay. Right now, I have 20 beds at the current time. They are full. The patient, they full. If they want to enter, they have to schedule 2 weeks later until one group finished, and then another turn. So during this July and August holiday period. It's the busiest time, patient, it's the patient need, encourage us to get to do this. A lot of criticism from, the colleague.
I'm not sure that the children in America could do this. I wonder if the panel could tell us if in their experience, if the children in India, Bolivia, or Italy if you could get children to do this.
6 years older and
6 years old, or even adult.
Yeah.
What's your impression from the rest of the panel?
For me, it's very hard to think in this treatment because I have a little claustrophobia, so I don't know. It sounds difficult.
I understand, yes. Yeah.
Young, this is quite interesting, I just wanted to ask, as Dr. Hurtle was also trying to ask, did this patient were in two groups, like the dark therapy exposure alone and both the together? Because I would assume through your presentation that all of these patients who had a dark exposure, they also did the some sort of therapy,
training.
right?
Mm-hmm.
So then how would we conclude that the effect individual?
That's a good question. Yeah, it's only one group. We have no control. We don't have a chance to compare without the training. Then all patients come out from the dark room and get trained for 2 weeks. And some patients even getting more training. They stay for more than a month because they saw the improvement. If we say you can go home, but they say no. For many years we don't get any improvement. Now I see the improvement. I want to continue until the end of the August. They have to go because the school is opened. Yeah, this is one group. That's a good question. As I mentioned that if we have a control, that will be better. But we don't, because no patient want to wait just after the dark room. If they have no effect, they lost their time. They don't want to participate in that group. Yeah, it's very difficult.
Yeah. All right, we have to move on now. I'd like to, for each of you on the panel, to give me about a 1 minute summary of what we've learned about amblyopia from the science, from your perspective in your talk. And we'll start with Matteo.
Hi. So I think that what we have to understand is that from a molecular perspective and from a physiological perspective, amblyopia is a very dynamic and complex phenomenon. And so it is Amblyogenesis. It is, of course, the title of our discussion today. And so I think that we have also to think as the eye as the same system that we can understand from not only from ophthalmological point of view, but it's very important also to consider it from a neurological point of view. And I think that amblyopia is very interesting, is a very fundamental example of how well brain and eye are connected. So how these two things have to be considered together.
Thank you. Vivek?
Yeah, I think it was a very great learning experience. And what I would add today, after this webinar is there are, apart from, the visual cortex, there are other areas that also get, excited in terms of, the subcortical part of the brain, like, the superior collicular pathways, or also the area in and around, the lateral geniculate nucleus, like, the putamen. So I think there are different structure apart from the visual cortex that is possibly we need to explore in the future. And also we need to give, the subtypes of, the amblyopia as a stimulus and see what happens, which part of the brain that gets activated. probably that would be the future perspective where we can have a different modes of the treatment in patients with amblyopia. And the third thing what today we learned is I think the adult amblyopia also a kind of a consideration in our day-to-day practice. So it's not age limit. We should all subject them for the treatment of amblyopia. Thank you.
Thank you. Sampara?
So what I would try to put it across is that though we talk about myopia as a global challenge, even amblyopia is also equally important in these patients. And we should not treat one part at a time, but have parallel strategies for both these groups. Now that we understand that there is a change in the accommodation, we should always look at all the aspects of binocular vision and orthoptics assessment as much as possible in the patients who have these problems together. So though we talk about amblyopiogenesis science based only on the cortex, but you should always look at the reflexes which we are seeing in day-to-day practice. Along with that, try to tailor-made the approaches towards high myopia patients where they are progressing. Along with that, there is a component of poor vision, not just the vision, but the contrast and other aspects of vision. We should take into account all those things. So that's what I would like to request everybody that, you should take these points also in practice when you are treating these patients, especially the patients who have anisometropia as well as form deprivation amblyopia. When we are treating them, treat them as a whole rather than treat as only visual acuity.
Thank you. Carla?
Well, I think that amblyopia is just the beginning in this huge and amazing work to prevent the amblyopia and to see. I saw how connected are the eye and the brain, and technology and the future is coming to help us. We have to improve in this way and day to day add something new that we found in our clinical consultation, and try to talk with the parents and the children the importance that amblyopia means, that strabismus and myopia also can join with amblyopia, but it's the beginning. So we have to try to make our big work in this age until 5 years old prevent. And of course, I know amblyopia can work in older people too, but it's important to work with children. It's the future. They going be maybe our doctors too. So we have to invert in the children. And amblyopia, I think it's a big point. Thank you.
Thank you, Carla. Dongsheng?
Yes, first I want to thank you to Dr. Hurtel, to Dr. Kikunaya for organizing this webinar. This is a very successful, very important event. So let us have opportunity to communicate with each other, learn from each other, and to update the research and in this field. And I really appreciate, Rich, you got so many questions. Usually it's the questions make our do a better job, and so it's not easy to do something new. And I think the DOC's approach actually break the concept that the visual plasticity in adult is already not exist, from our result, although it's just from the patient with nystagmus. But, to get their vision to the normal, I don't see any report in this large group of people. So I feel that I did something for, to help the people who needed this help. And I'm so happy to share my results with you. And thank you for letting me participate in this webinar. Thank you.
Thank you. Ramesh?
Yeah, thanks, Rach. I think people just look at visual acuity when you're treating, amblyopia patient. I think it's very, very important to look at all the components of vision. And the whole thing is, the whole purpose of this Amblyogenesis webinar is to understand how brain contributes to this rather than just looking at that eye. So think about brain, think about beyond visual acuity. These are my two messages for everyone.
Ramesh, you want to wrap us up?
Yeah, I know we are just 2 minutes over time, but I have some exciting news to share. I would like the delegates to be staying on for the next 2 to 3 minutes. So we had a wonderful webinar. People could ask, why didn't we include the treatment today? Because we just focused on Amblyogenesis today. We have one more webinar coming as a part 2 of this, where many people would like to clear their doubts. And if you have any questions, I can see a lot of questions which are unanswered. Please email them to admin@WSPOS, and we will have them responded, and we will email them to you if you have more questions. As always, World Society of Pediatric Ophthalmology is a leader in this webinar sessions. And we have, in this season, 3 more webinars coming up. First one is the practice management and career development for pediatric ophthalmologists as a part of UC. Second one is on 4th October. We'll have procedural comforts in pediatric ophthalmology. And on November 15th is the part 2 of this webinar. Again, it's a part of IME. IME is independent medical education. So this is the newer treatment of amblyopia. I would like everyone to contribute again there. And the question is, most of the participants around the world, who are the members, we have more than 6,000 members of World Society of Pediatric Ophthalmology. They're all looking for a venue for the World Congress of Pediatric Ophthalmology and Strabismus, 6th World Congress. Any guesses? Any guesses? I don't want to take more time. It is finalized. This would be in the 6th World Congress would be in Cancun, Mexico. We would like you to be there. Start preparing. Put your best papers, put your best videos, put your best cases, put your best presentation. Keep preparing. It's on May 13th to 15th, 2027. It's not very far. It's coming up very soon. So we would like to welcome you all and start preparing for this exciting venue in Mexico. I would like to, remind all our delegates to complete this global survey on pediatric IOL implantation. And also, you will get a free registration for the 6th World Congress for the 5 winners after completing this. So make use of this. Who knows, you could be one of the winners to be there in Mexico in 2027. We have a wonderful subspecialty program. It's a day long. It's a compact program. It's going to be in Copenhagen. It's on 12th September. Please be there and please register. We have a really, really wonderful capsule put for every one of you. And it also has some industry-sponsored fantastic sessions, breakfast symposium, lunchtime symposium, and networking symposium. And most importantly, we also have a Myopia Innovation Summit. Just stay back out of the subspecialty. We have a 2.5 hours program with the myopia innovations and also emerging therapies in pediatric ophthalmology. So don't miss this in 2025. It's in and those of you haven't uploaded or downloaded this myopia consensus statement. This is for the parents and also for the professionals. Just download them. And these are the QR code for the same. You can just take direct link to the consensus statement And also you can go into the website landing page. These are the QR code, quick response code for this. As many of you join WSPOS, it's a wonderful association. It's a wonderful place to learn and share knowledge. Education is kind of democratized. We can learn from every expert in the world. So join, it's free. And also you can join us at the Facebook and other social media handles. More importantly, I would like to join our younger colleagues to our pediatric ophthalmology listserv. This is mainly run by Dr. David Granite, and you could send him an email with the following details, and you will be at daily learning from around the world. I would like to thank all of our audience. I know this is not just a live program. You can watch this program. It's there on the YouTube. You can ask your colleagues to watch along with you. You can ask your residents and the fellows to watch this webinar. I would like to really thank my speakers for their contribution and also their participation today. I would like to thank Rich as well for a wonderful moderation of today's webinar. As always, this education is sponsored by our colleagues from Binox and also our Revital Vision, which is a novel therapy for amblyopia. Thank you very much. As always, the NTOT hosts this platform for all of us for education. Thank you so much, NTOT. Last but not the least, there are people behind. There are two women behind this whole webinar. Number one, it's Akhila, and number two, it's Caroline. Both of them, thank you very much for working very, very hard behind the screen. I would like to thank everyone and close this webinar. Very good morning, good afternoon, good evening, and good night who are reaching the late night today. Thank you so much. Thank you very much.
Thanks, everybody. Great job. Thank you.
Thank you. Thank you. We'll see you in a few days, Dr. Hurtle.
Oh, I see you. See you next week. All right. Bye, guys.
See you next week.
Bye-bye. Take care.
Bye.